Hi everybody, and welcome to our module on wound healing and scar. Wound healing is necessary anytime there is damage from inflammation or cell death. And there are a couple of ways that our body deals with wound healing. Ideally, our body tries to regenerate tissues, and this occurs in tissues that have the capacity to replace damaged cells. For example, if they have surviving cells capable of cell division or if the damage has been minor. The other way our body deals with wound healing is through scar formation. This occurs in tissues that are not capable of regenerating lost cells, or in tissues where there was severe damage that destroyed the normal regenerative capacity of the tissues. In this case, in scar formation, lost cells are replaced by connective tissue. This is a process known as fibrosis, where scar tissue is left behind at sites of inflammation. And if you've ever had a deep wound, that wound destroys the ability of your skin to regenerate itself, and therefore you may have a scar where that wound was. Let's talk about the different types of tissues in our body and how each of them handles the process of wound healing. Tissues that are called labile are continuously dividing even under normal conditions to replace lost cells. So for example, your hematopoietic stem cells are always dividing to generate new red cells and white cells even under normal conditions. The same is true for most tissues that contain epithelial cells like your skin or the lining of your GI tract. These tissue beds are always losing cells and regenerating new cells. What this means is when it comes to wound healing, these tissues easily regenerate unless the wound is so severe that it's damaged the regenerative capacity. Another type of tissues found in our body are so-called stable tissues. These tissues contain inactive or quiescent cells that normally don't replicate very much at all. However, they can proliferate and replicate in response to injury. And some examples of stable tissues include most solid organs like the liver, the kidney, the pancreas. You may know that some people donate part of their liver. It's called a partial liver donation, and the liver that's removed will grow back. The liver is not normally replicating to that degree, but it can do so after an injury. And then the last tissue type are the so-called permanent tissues. These tissues are said to be terminally differentiated, which means they have grown into what they are going to be for the rest of their life, and they do not proliferate. They have very limited proliferative ability. These types of tissues cannot significantly regenerate, and the two types of tissues classically referred to as permanent are neurons and cardiac myocytes. Since these types of cells do not regenerate under normal conditions, anytime there's damage, this is going to lead to scar. So all of my patients who've had a myocardial infarction now have scar tissue in their heart, and that's because the myocardium and the myocytes are not able to regrow new cells. Let's talk a little bit about stem cells. So the mature cells in many tissue beds have a short lifespan, and the way the body deals with this is by having a subset of cells called stem cells that can replace the lost cells. And all stem cells have two abilities. The first is called self-renewal, and the second is called asymmetric division. What this means is that each stem cell is capable of dividing into two daughter cells. One can go on and become a mature cell to replace a lost cell. The other one can become a stem cell so that you never lose a stem cell. That's called self-renewal and asymmetric division, and these are properties of all stem cells. Embryonic stem cells are found in the embryo, as their name implies. Specifically, they're found in the blastocyst. They're completely undifferentiated, meaning they don't look like skin cells or glandular cells or anything yet. They are capable of growing into many of these cell types later on in their life. And these are very important for embryogenesis. These stem cells go on to form the entire body. Adult stem cells are the type you find in adults, as the name implies. They're found in our tissue beds. They are more differentiated, and they produce cells for only one type of tissue. For example, your skin has skin stem cells, which can regrow lost skin cells. The epithelial lining of your GI tract has stem cells in the basal layer, and when epithelial cells are lost into the GI tract, they can be replaced by those stem cells. And these are important for the process known as homeostasis, which is keeping the body in balance by replacing lost cells so it doesn't lose cells over time. Okay, so now that we've talked about those basic concepts, we can get into the details of how scar forms. And you can basically think of scar formation as a sequence of three processes. The first thing that happens is new blood vessels need to grow into the area where the scar is going to form. This is called angiogenesis. The second thing that happens is fibroblasts need to become activated. These cells are key to laying down scar tissue. They need to migrate to the injury site, they need to proliferate, and they need to lay down fibrous tissue. And then the final step is that the scar needs to mature. So over time there are changes to scar composition and structure, and this produces a stable, stronger scar tissue in the area where the scar is going to be indefinitely. Critical to the whole process of scar formation are growth factors. Growth factors are substances that are released by cells that drive scar formation. And there are many, many growth factors that have been described as playing a role in scar formation, including all of the ones on this slide here. They trigger various processes that are important to scar formation, things like chemotaxis, drawing in fibroblasts and other cells, angiogenesis, and fibrosis. And so as we go through describing the process of scar formation, I'll mention these growth factors and try to tell you a little bit more about what they do. So as I said before, the first step in scar formation is angiogenesis. New vessels need to grow from existing vessels into the area where tissue has been damaged. Obviously, the damaged area no longer has normal blood vessels, so new ones need to grow. And you should know that new vessels usually grow from venules. It's high yield to remember this fact. And the two key growth factors in scar formation that drive angiogenesis are VEGF and fibroblast growth factor. So VEGF stands for vascular endothelial growth factor, and this is actually a family of signaling proteins. There are several VEGFs, like VEGF A, B, C, and D, for example. VEGF A is a very important growth factor that stimulates angiogenesis, and it's important in scar formation. It's also very important because it's secreted by tumors, and this allows vascular growth so the tumor can continue to grow in size. And because it plays a role in vessel growth in pathologic situations, there are a couple of VEGF inhibitors that are used as pharmaceutical agents. So bevacizumab is used in some forms of cancer to stop blood vessel growth, and ranibizumab is used in retinopathy to prevent neovascularization of the retina. FGFs are fibroblast growth factor. They come from macrophages, also mast cells, also endothelial cells, and they get their name of fibroblast growth factors because they attract fibroblasts. They are chemotactic to fibroblasts. And it's easy to remember that they draw in fibroblasts, but what you really need to remember about fibroblast growth factors is that they are also powerful angiogenesis growth factors. So they stimulate growth of new blood vessels as well as drawing in fibroblasts. They also stimulate the fibroblasts to begin synthesizing extracellular matrix proteins. So that's a nice segue into talking about fibroblasts. These cells are key to scar formation. They migrate to sites of injury and they synthesize and secrete extracellular matrix proteins. Initially, when they arrive at a site of injury and they begin to form scar tissue, they secrete type 3 collagen and fibronectin, two substances that are part of early scar formation. Later, however, collagen type 3 will be broken down and the fibroblasts will begin to secrete collagen type 1, which is much stronger. So it's very high yield to remember that initially fibroblasts secrete type 3 collagen, but later you will find only type 1 collagen in scars because the type 3 has been broken down. So we've already talked about how fibroblast growth factors are important stimulators of fibroblast cells, but two other key growth factors that also play a role in scar formation are TGF-beta and PDGF, and we'll talk about both of these in just a second. But before I get to the growth factors, I want to talk about vitamin C, also known as ascorbic acid. I talk about this in detail in the vitamin videos in the biochemistry section. Vitamin C is found in fruits and vegetables like the one shown on the screen here, and it's necessary for collagen synthesis. And what this means is patients who are deficient in vitamin C will have poor wound healing. Vitamin C deficiency is also known as scurvy. It has a number of clinical features, but one of the important ones is poor wound healing, and that's because those fibroblasts aren't able to synthesize collagen normally. So now let's talk about those two fibroblast growth factors, and the first one is TGF-beta, which is transforming growth factor beta. This is released by many different cell types, including platelets, T cells, and macrophages, as well as endothelial cells and some others. And in general, it has two roles. The first thing it does is promotes healing and scar formation, and it does this by stimulating collagen production and inhibiting collagen breakdown. So one of the things it does is drive fibroblasts to start making collagen as part of the process of healing and scar formation. Its second major role is as an anti-inflammatory. It can inhibit lymphocyte proliferation and activity, and one of the ways we know this is there have been a number of knockout mice studies. These are studies where mice are bred with no gene for TGF-beta, and what happens to these mice is they suffer from widespread inflammation. So that's how we know that it's a very powerful anti-inflammatory in addition to its role at promoting healing and scar formation. PDGF is platelet-derived growth factor, and it gets that name because it comes from platelets as well as macrophages and endothelial cells. And it's sort of unfortunate that the word platelet is in its name, because really what you wish was in its name was the word fibroblast, and that's because this is a powerful stimulator of fibroblasts and also smooth muscle cells. It can trigger growth and migration of fibroblasts. It can also trigger synthesis of collagen. And for this reason, it's been implicated in a number of disorders that involve excessive fibroblast activity. This includes includes myelofibrosis, a disorder of bone marrow, and scleroderma, which is an autoimmune condition that involves excessive fibrous tissue. So I always think of PGF as ending in the word fibroblast. I wish fibroblast were in the name itself, but it just is not. Let's talk about the term granulation tissue. Granulation tissue is tissue you can see 3 to 5 days after an injury, and it represents the early stages of healing and scar formation. You want to be familiar with this term, especially in your third year on your surgical rotations, because surgeons will often refer to the presence of granulation tissue within a wound. It's made up of collagen and new blood vessels, and if you look at it under the microscope, you see things that should make sense to you at this point in this video. You see proliferating fibroblasts because they're important for scar tissue formation. You see small new capillaries forming from angiogenesis. You also see some extracellular matrix that's been laid down by fibroblasts, and you can also see some inflammatory cells, especially macrophages, and eventually the granulation tissue will turn into scar. Here's a picture from the web of granulation tissue. You can see that it's red. That's because of the blood vessels. If you could touch it, it's also sort of wet and sticky, and that's that extracellular matrix that's being laid down. Eventually, this will be a big scar on this person's skin, but right now it's not yet scar, it's granulation tissue. Myofibroblasts are a special type of fibroblast that contain contractile proteins. They share many similarities with smooth muscle cells, and their role in scar formation is that they contract the wound, they pull the edges together, and because of these cells, wounds actually shrink over time. If you have a large wound on your skin, over time it will get smaller because these cells pull the edges together. They initially develop within wounds around day 5 after an injury, and they're lost by apoptosis as the scar matures. What you want to remember is these are the cells responsible for contractions of wounds. So earlier I told you that the third process in scar formation is scar maturation, and that involves something known as remodeling. So remodeling refers to modification of connective tissue over time. After the initial synthesis and deposition of connective tissue by fibroblasts, it changes over time. One of the key features is the breakdown of type 3 collagens, as I mentioned before. They are replaced by type 1 collagens. In addition, there is cross-linking of collagen to make the scar stronger. And key enzymes involved in this part of scar formation include metalloproteinases, which require zinc, and the enzyme lysyl oxidase, which requires copper. And so as we'll see, you need zinc and copper in your body to appropriately form scars. Metalloproteinases get their name because they are enzymes that contain metal. Specifically, they contain zinc. And I've shown a picture of a penny on the screen here to remind you that these enzymes contain zinc. Many people think pennies are made of copper, but they're actually made up mostly of zinc. You can share that fact with all your friends at the next party you go to, and they'll think that you're a big nerd. But anyway, the role of metalloproteinases in terms of scar formation is to degrade proteins in the extracellular matrix. This makes them important for the maturation phase of wound healing. And one thing they do that it's high yield for you to know about for step 1 is they break down type 3 collagen. They are said to possess collagenase activity, and we talked earlier about how initially scars have type 3 collagen, but it goes away, and one of the reasons it goes away is because of these enzymes. The fact that these enzymes contain zinc also means that patients with a zinc deficiency will suffer from poor wound healing. Specifically, they will have problems during the maturation phase of scar formation. So here's a graph showing the changes in the elements of scar tissue over time. So as we talked about earlier, initially fibroblasts lay down type 3 collagen and fibronectin. These structures are very useful as scaffolding early in scar formation, but they're not very strong. So as the scar begins to form, then the fibronectin and the collagen type 3 goes away, and it's all replaced by collagen type 1, which is much stronger and ultimately allows for a stronger wound. And here's an interesting fact. If you could plot the wound strength on this graph, what you would see is that it would go up, 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 and then keep going up even after the amount of type 1 collagen that is going to be formed has plateaued. So after a few weeks, all of the type 1 collagen that's ultimately going to be present in the wound has been laid down. However, the wound strength continues to increase until about 2 or 3 months, and that's because of that maturation process and all the cross-linking of collagen that is going on. I mentioned lysyl oxidase before. This is a copper-dependent enzyme. Its role in scar formation is to cross-link collagen to make scars stronger. And so what this means is in patients who have a copper deficiency, they will display poor wound healing. Specifically, they will display a poor maturation phase of scar formation. Let's talk about the ways that skinned wounds heal, because these have been extensively described in the literature because for hundreds of years surgeons have been dealing with skin wounds. There are 2 general ways by which skin wounds heal. The first way is called first intention and the second way is called second intention. In healing by first intention, the tissue surfaces of the skin are approximated, which means they are closed together. This is a common method of healing for surgical incision sites. The surgeon brings the edges of the skin together and then attaches them to each other with either sutures, staples, skin glue, or tape. The important thing to know about first intention is that this requires that there be relatively small amounts of tissue lost. You can't bring the edges together if you have a massive gaping wound, but if you have a small wound like a surgical incision wound, then it's usually easy to bring the edges together and heal by first intention. In this situation, the main mechanism of healing is epithelial regeneration. That's because by approximating the edges, you are bringing the epithelial layers of skin together. There will be minimal scar and there will be minimal wound contraction. Most of the healing will be by epithelial regeneration, and it's high yield to know this for your exams. In contrast, healing by second intention is what must happen for large wounds. You can't bring the edges together. The classic example is a pressure ulcer on the back of someone who's been bedbound for a long time. You just have to let it heal on its own, and there will be a large scar present once it heals. So just to make this more clear, here's a surgical wound on the left side. It's been stitched together. This wound is healed by first intention, and notice that there's relatively little scar tissue here. On the right side is a large gaping pressure ulcer. You will see these, unfortunately, in many bedbound hospitalized patients. There's no way to bring these edges together and stitch them together and get them to stay. The wound will just fall apart. So you have to leave it open and it will heal by what's known as second intention. So now that we understand the basic idea of what we mean by healing by first intention or second intention, let's drill down on some of the details of how skin heals by first intention. At the injury site, when skin heals by first intention, there are two problems the body has to deal with. There is some tissue loss, and there's also blood loss because vessels have been damaged. So in the first 24 hours, the main thing that's going to happen is inflammation is going to begin and hemostasis is going to occur to stop blood loss from those damaged vessels. This means that clots are going to form and platelets are going to be drawn into the wound site. In addition, neutrophils are going to invade via increased vascular permeability, the same way I talk about in the video on acute inflammation. This is basically acute inflammatory process in the first 24 hours going on within that wound that is healing by first intention. After a few days, the neutrophils are replaced by macrophages, and I talk about how this occurs in the videos on acute and chronic inflammation. Neutrophils only last a couple of days. Beyond that, macrophages take their place. During the first week or so, new blood vessels are going to grow, just like we talked about earlier in this video, in order for scar to form. Fibroblasts will infiltrate the area that is going to have a scar, and granulation tissue will form. Type 3 collagen will be laid down, and wound contraction will occur via the myofibroblasts like we talked about earlier. So even though I told you the major process involved in healing by first intention is epithelial regeneration, there is still scar tissue formation, and these things are going on just like they do in formation of all scars. And then finally, after a few weeks, the scar tissue will remodel. The type 3 collagen will be replaced by type 1 collagen, and the metalloproteinases will come in to begin cross-linking collagen. So here's a graph similar to graphs you can find in many textbooks describing the cells that are involved in all forms of wound healing, including wound healing by first intention. The neutrophils come in the first few days and go away. They're replaced by macrophages, and then after a week or so, the main cells you find within the wound are fibroblasts. Very high yield to know what's on this slide for your boards. Very simple board questions can be made up by asking you about what cells are present a certain number of days after a wound. So that's healing by first intention. What about by second intention? Well, it's basically the same thing, except there's more inflammation, more granulation tissue, more myofibroblast initiated tissue contraction, and ultimately much more scar tissue because you don't get as much epithelial cell regeneration. Let's talk about the long-term outcomes of scar formation. You should know that scar remodeling continues for 6 to 12 months. And this is important to know clinically. Some of my patients who come to see me 6 or 8 months after bypass surgery will still have twinges of pain in their chest around the wound, and that's because the wound is continuing to mature during that period of time. Eventually, what's known as a mature scar will form. Mature scars are avascular and acellular. All they have are fibrous tissue. All the cells and all the blood vessels have gone away. Over time, the mechanical strength of scars grows. We've already talked about how type 1 collagen content grows, and type 1 collagen is stronger than type 3 collagen. In addition, the collagen synthesis stops after a few weeks, but collagen cross-linking persists long thereafter. This means the scar will get stronger over time. The tensile strength will ultimately be stronger than it is initially after the wound begins, but it will never equal that of normal tissue, and it's important to know this. No scar is ever as strong in terms of tensile strength as the tissue that was there before the wound. Next, let's talk about keloids. Keloids are raised scars. This is a picture of one on the abdomen shown here. This is a major cosmetic problem because the scar is unsightly. People who are prone to these can develop keloids not only after surgery, but also after cuts or burns, even after a chickenpox infection with skin lesions. It often takes several months for this to appear, so initially the wound can appear minor, but then several months later there can be a large growth of scar tissue like what's shown on the screen. In addition to the fact that the scar is raised, keloids extend beyond the borders of the initial wound, and it's high yield to know this for your board. So this is a bigger problem. Not only is the scar raised, but it's bigger than the initial wound was. The cause is basically excessive healing and scar formation. There are more fibroblasts that are growing, more fibroblasts producing collagen, more growth factors present, just more of the entire scar formation process. And you should be aware that this problem is 15 times more common in people with dark skin. You'll rarely see it among Caucasians. You'll commonly see it among African Americans, sometimes people who are Asian, and even sometimes people who are Spanish. Keloids contain type 1 and type 3 collagen. It's high yield to know this. All of the type 3 collagen is normally replaced by type 1. That does not happen in keloids. In addition, the collagen is disorganized. So normal skin has collagen that is nice and parallel to the epithelium. That does not occur in keloids. The collagen is laid down in a very disorganized manner. These types of scars are much more common in certain locations. They're highly common in the earlobe, also on the shoulder and in the upper back. They're very rare on the eyelids or the palms or soles. And because they're unsightly, people often want to have them removed. But unfortunately, if you surgically remove the keloid, it's very likely that it will just recur. So when these have to be treated, usually for cosmetic reasons, they're treated by injecting corticosteroids or sometimes 5-FU into the keloid to try and break down the tissue. There's another type of abnormal scar formation called a hypertrophic scar, and these are usually discussed together with keloids because they share some similarities. Just like keloids, hypertrophic scars also involve excessive scar formation and excessive fibroblast activity. These usually develop about 4 weeks after an injury, and in contrast to keloids, the hypertrophic scar remains within the wound borders, does not spread beyond the wound borders. This is a picture of one on the screen here. You can see it sort of looks like a normal scar. It's just built up a little bit more. It's raised a little bit above the skin and bigger than it should be for a normal scar, therefore it's called hypertrophic. Important to know that histologically, these types of scars contain mostly type 3 collagen. In contrast to keloids, however, the collagen fibers remain parallel with the epithelium. They are not disorganized the way keloid collagen fibers are. Also, in contrast to keloids, these are common in all demographics. There's no specific demographic. These can occur anywhere on the body, and they often regress spontaneously. In terms of cosmetics, these are usually less of a problem than keloids. I'll finish by mentioning wound infections. These disrupt the healing process and they prolong the inflammation phase. If you've ever seen pus, pus is bacteria and dead neutrophils, and that's present when there is an infection that disrupts wound healing. For example, this picture of this man on the screen, he has a little pustule right here next to his eye. That is a wound that is not undergoing the normal healing process, and that's because bacteria have gotten into it, and now it contains pus, which are bacteria and neutrophils. When bacteria get into a wound, the inflammatory cytokine release continues and there's poor formation of growth factors. So basically, the entire process of healing is disrupted. And I won't go into all the bacteria that can cause wound infections. I talk about these things in videos in the infectious disease section. But by way of brief review, Staph aureus is a normal colonizer of our skin, so it commonly causes wound infections. Clostridium tetani can get into wounds and can lead to tetanus. This is why people are vaccinated after injuries in many cases. Pseudomonas is a classic bacteria to cause infection in patients who have burn wounds. Rabies virus can infect people and infect wounds in people who get bitten by animals. And for this reason, rabies vaccination is sometimes done after animal bites. And then finally, Vibrio vulnificus is a famous infector of wounds when wounds are exposed to contaminated water. And that concludes our video on wound healing and scar.